Good evening, everybody. Welcome to the Chappaqua Central School District Board of Education meeting for Wednesday, November 13th. The board's been in executive session, so can I have a motion to bring us back to the public meeting at 6:17?
I'll move. I'll second.
All in favor? Aye. Pledge of allegiance. Pledge allegiance to the flag of the United States of America and to the republic which stands one nation under God, indivisible, with liberty and justice for all. All right, well, we have some guests tonight, and we're going to actually get started with them so they can go out with their evening, and then we'll turn to our regular business. So,
May I?
Dr. Ackerman, yeah, please.
So I'm pleased to welcome Dr. Pura and Ms. Bounds from Northwell Health. And we've asked them to come to the meeting tonight because we've been speaking with Northwell Health since probably early summer about a potential partnership, not only with us, but other school districts in the region, to increase our mental health support and capacity for our students. And so as a part of that process and planning forward for potentially this partnership next year, I'd asked Northwell Health to come in and speak with the Board of Education just to talk about their program, this opportunity. Andrew and I actually had the fortunate experience of being able to go and speak with superintendents from Long Island, where this partnership is currently in place, through Grace's also a representative from the hospital in Kiva. They have put us in contact with other school districts that have this partnership in place already, and it's been an amazing experience for both the staff supporting our students and their families there. So I'd like to now turn it over to both of you, and thank you for joining us this evening.
Thank you. I'm Gina Marie Bounds. I'm the Assistant Vice President for Pediatrics at Northwell.
So really thank you, just to set the background, and I think that none of the information on this slide is probably new information. This is something that has been well known and well published on and well spoken about, especially since the pandemic, of youth mental health issues being on the rise and having a crisis around both escalating problems and a lack of access in the community, and then the care getting pushed into more acute care settings like the hospital or emergency departments, and really having this problem become an issue and sort of top of mind also for schools and school boards and all kinds of initiatives around the country and in this state in trying to help schools to be able to provide more mental health services for students and access to care. So with that, really what we have done in Long Island and we're hoping to accomplish here is to partner with school districts and partner with communities to provide care and to kind of innovate and think anew about what systems do work and what doesn't work. And really the model that we came up with is truly innovative in that it really helps create a care space that doesn't currently exist, that lives somewhere between the hospital and between an outpatient service that really does allow us to provide immediate access for students in need of evaluation or timely access for those who need that. But that we really support that and don't stop at the crisis and really work with the community to kind of get ahead and provide preventive services, early identification, and we'll talk about what are the kinds of things that we do for that, and to overall change culture and help support initiatives to promote equity and decrease stigma in the community at large that exists around mental health and accessing mental health. And really, our clinical model has been congruent with best practices in school mental health, which is this multi-tiered systems of support that schools follow for providing the entire community and recognizing that different members of the community need different levels of support, and really recognizing that at tier one, everybody needs education and everybody needs sort of preventive services, mental health literacy training, staff support, professional development, parent support, parent education, direct-to-student health education as mandated by New York State to include mental health topics. And on this level, we also have a really great peer-led youth mental health advocacy program, because it's a really important component of our work is amplifying youth voices and really having the kids help us lead and come up with some of the solutions on how to support them best. And then at the second level, at tier 2, we have secondary prevention, which is, again, kids that are identified to be at risk that you're currently maybe getting support and help with from various sources, with consultations that support the CSE process or other processes in the district that requires that expertise from a child psychiatrist, or we now also have a neuropsychologist that provides that support. And that is also the consultation is also supported and enhanced by care coordination for the family, so that when services are recommended, it's not just a recommendation, but there's actual tangible help in getting the family connected to the care that's being recommended. And then on the top, at the treatment level for the highest risk students, again, that is the brick and mortar clinical care space that we have. They're called behavioral health centers in the community. You'll see in a minute pictures and what it looks like in Long Island. The idea is, again, creating a care space that's not threatening, that feels like a pediatric office, and that's what it feels like. It's welcoming, colorful, really just a space where people don't feel intimidated to come. And this care space, the clinical model is providing evaluations, assessments by child psychiatry-led team, and also providing short-term stabilization treatment, because even with our help and care coordination, it still takes time to connect to care, and we don't want delays in care. So if somebody is coming and has such high levels of anxiety, for example, that they really need treatment immediately, we're able to start that treatment until we're able to link the family with care and then connect them to the care that they need. And if we have to escalate their care from the community to the hospital, we're able to support families and schools in navigating that upward care space as well. And although the goal is, again, that together we'll see more kids earlier and have less crises and less need for the hospital and emergency services.
So to go into our tiered model a little bit in more detail, our tier 3 services, the top part of that pyramid could be achieved in multiple ways. So as Vera mentioned, the behavioral health center evaluation is a brick and mortar site led by a child psychiatrist, where you would have immediate access to care for any of those urgent, or like I like to call those near crisis or pre-crisis patients and students. We also, as Vera mentioned, offer short-term care. This is really helpful before we link a student to care. So if they are identified to needing treatment, whether it's therapy or medication, we can hold on to them until we softly, I like to call it a warm transfer them to a provider in the community. But this is also really helpful if a child who already is receiving care in the community, their psychiatrist is out of the country for a month on vacation, or maybe they're on medical leave, or what often happens is people are between insurance or between jobs, and they might have that lapse in care. And so we're kind of able to hold on to them for that short-term bridge. We also have other programs that are very specific to certain mental health concerns. And so we have a short-term program for school avoidance, and then we have one for anxiety and high risk. Both these programs work directly, typically with group, sometimes with individual, but work directly with students and often with the families as a whole. We can also help with triaging for the ED and hospital navigation. So there are times where the school or a parent may call us, and we may quickly over the phone determine that that patient or that student needs a higher level of care. But we're not going to just hang up the phone and say, go to your closest ER. We're going to help navigate, especially when we're in an area where we have an ER that's within our family, within Northwell. We're going to make sure that we're giving the heads up. If it requires an ambulance, which is very rare, but sometimes that there is a need for that, we're going to call our Northwell ambulance. We're going to have a lights out, very quiet back door transfer, so it's not any more traumatic to that student than it needs to be. The other thing that we'll do is linkage support. So you may not consider linkage support to be that tier 3 urgent crisis care, but it is in fact piggybacks off of that. So sometimes we'll get students who have had an inpatient stay, or maybe they've spent a night in the ER, and now they're going to come back to school or back into the community, and we're going to help ease them in. So we'll get a call, especially if it's from our ER or our inpatient stay unit or the parent themselves, and we'll kind of help with in collaboration with the inpatient team or ER team, how do we navigate this child back into their community, back at school, and connect them with a local provider to help them? Or perhaps they go into one of our short-term programs like the school avoidance and anxiety high-risk program I talked about. And the last thing is very unique to our program. It's this crisis postvention support. This is where we pull together 3 separate teams at Northwell that come together, what we call our school crisis response team. This honestly naturally evolved on its own as each, unfortunately, as various communities on Long Island experienced some type of crisis or tragedy. It might have been that bus accident, if you heard about in one of our communities on Long Island, where there was a very beloved teacher that passed away. We've had jet ski accidents, house fires, any type of death of a student or faculty member on the staff. Will come in and deploy our crisis response team, and that team will go on the ground into the schools. They'll work with the faculty, they'll work with the clinicians in the school, those school psychologists and counselors, and really develop a plan very specific, obviously, and customized to what the crisis is on how do we deploy help. Are we supporting the staff? Are we supporting the students? Are we supporting the families? And we really use all resources and, of course, evidence-based research, how to best navigate those difficult times.
Yeah, I think the hub here just sort of further highlights that triage clinical support functionality, which our school partners really appreciate. So that school clinicians, when they have cases, they have the ability to call and get on phone with a clinician before referring to talk through cases, to get support, to get guidance, and like Gina Marie described, to figure out what is the next best step for that student and able to navigate that. The hub, which is our central team that helps supports the individual centers in Long Island, also helps with care coordination. Parents can call and get support. They can get resources, education, connection to services, sort of all kinds of things that we're curating for them to be able to provide when they're calling with a question or needing support. So that has been something that we've been growing and that the families and the schools find extremely helpful to have that real-time support. This is what the sites look like. We do on the one on the left side of the screen, the pictures are the current sites in the 3 different locations and their rooms. And the 2 pictures on the right are drawings of the potential site here in Westchester, which we do have a location in Mount Kisco identified where we are hoping to open the center. And look how pretty it will be.
Yeah, I just want to note for these pictures, the whole purpose was to be very non-clinical, non-sterile, and to be a really welcoming environment for the kids. So we take very close attention to whether or not we have a playroom, artwork. Actually, a lot of our artwork is student drawn. So we do an art contest every year, and the winners of that, of course, we get permission and we make them into canvases to put around the center. But it really was, we didn't want anyone to feel like they were going to a medical office or any type of real clinical environment, but to be much more therapeutic.
And we sort of reviewed this already, but again, the goal of the visit there is to get that assessment, to get guidance, to get education, to get started with treatment if that applies, and get connected to care for ongoing services, and to support everybody in the process, including the school, the families, and whenever possible, help avoid the emergency department and the hospital. And this is what the patients experience when they come, whether the identification comes. This is a really important feature of the program, as opposed to other school-based endeavors. When patients come to us, they become patients of Northwell Health in a separate entity. So the information sharing between the school and the behavioral health center is contingent upon parent HIPAA releases. And also, we take patients, whether they're referred by the school or by themselves or by their pediatrician or by their spiritual leader, whoever identifies that there's an issue can send the student or the child or the adolescent to the center, which is really wonderful because it does allow for really removal of barriers around accessing the care that's available. If there is a referral coming in from an identified colleague from school or pediatrician, we do get some information from them on a notification we schedule. If it's a crisis, we schedule the same day, and then the family comes for the evaluation. If there's a consent, there's feedback to the school going back, and then there's short-term treatment again when it's applicable and connection to ongoing care. And all throughout the time, there's clinical decision support for the staff. All throughout the time we're engaging the parents, there's education, support, and guidance and care coordination available from them through the process. And this already, we spoke about the crisis postvention support.
So for the tier 2 services, this is the part of the pyramid in the middle that's really for those at-risk students. We offer in-district psychiatric evaluation. So this is different than an evaluation one might have if they went to the behavioral health center. That's if you think about they're coming as a patient of Northwell. This is that in-district psychiatric evaluation that you're probably ordering already. You might use a private psychiatrist in the community. This is often used to help support a child through the CSE or 504 process to help give more information to how to best meet those child's educational needs. And we do that kind of on an ad hoc basis, as needed and ordered by the school district. In the same respect of having these ad hoc psychiatric evaluations, we also offer neuropsychology evaluations, which is unique because that's usually a much harder evaluation to get. It's a very specialized provider that can do that. We have the school avoidance consultation and parent education program, and this is really offered to anyone, so you don't have to be a current patient, but do have to be signed up for that school avoidance program. We do the linkage to resources. So not everyone needs a crisis appointment today, or not even sure they need it at all, but maybe they want some resources. They have some concerns about their kids. They can call the center and find out, these are my concerns, what would you suggest? And if it's not, obviously nothing that clinically needs to be seen immediately, we could link them to community resources. And then we have the care coordination for that. So I think what's unique about us is rather than just giving somebody a printed sheet, which is often 6 years old, of all the various providers in the community, we start to curate a very customized database for that community. And so we build this database by going out in the community, meeting all the providers. We find out who the providers are, what gender, what language, what insurance, who's taking new visits, where do they live, so that when our patients come to see us, we're not handing out that 6-year-old sheet of resources of everyone, right? We're handing that, we're doing our click into our database so that we're giving them a very customized report based on what their insurance, language, or transportation barrier they may have. And again, we know who's taking new visits in the community. So if we're connected with, says, hey, listen, I closed my panel, for the next 3 months, I can't take any new patients, we're not offering that resource. Where we can, we will call, make the appointment ourselves. And then once we're really more established in the community, there are some community resources that will give us our own slots, and we can directly schedule into them.
And then tier 1 is those preventive supports, which really are wide-reaching and all about engaging the entire community. And they're broken down here, what goes to the parents and the students and what goes to the staff. I will say we're very engaged with our schools. We'll meet with them regularly. They get to know us. The clinical teams at the centers become sort of extension of their clinical teams. They'll know each other. They work together. They get on the phone regularly, and we get on the Zoom. Just this morning, we had a session for all of our schools. That's our case discussion session. That's de-identified cases and case-based learning for everybody, and teach all, learn all. It's called Project Echo. And we talked today about students impacted by trauma was the topic. But we have regular meetings is the point, and they really, we work together as a team, and lots of education and support available for the community and for schools. And yeah.
So we're just under 5 years into the program. We started out in January of 2020, interesting timing, with 5 school districts. And so in the almost 5 years, we now have partnerships with 54 school districts, which includes 304 buildings. This number is a little higher now. It's over 220 students on Long Island now have immediate access to a child psychiatrist through this partnership. 2,000 school staff have been trained yearly, so through the professional development, which is important for the various mental health challenges that our youth deal with, but also for early detection. We've had year to date since opening, 10,000, actually over 10,000, probably 12,000. Oh God, that was 2 months ago. 12,000 visits to the Behavioral Health Center. Again, immediate access to care. 2,500 school psychiatry consults. So those are those kind of ad hoc evaluations I was talking about, where a school district needs that information to help better meet the educational needs of their students. 91% of our students are connected to care within the first visit. The other 9% isn't because we couldn't figure it out, but some families decline, and that's okay. That's obviously their choice to do that. Or some already have a provider that they're just going to continue with. And, it was interesting in the first couple of years that we opened up, we were able to do this on Long Island because the first center that we opened was in Nassau County within 15, 20 minutes of our Cohen Children's Behavioral Health Center, or our Cohen Children's ER. And what we noticed after pulling the data a year after opening up the program is we saw a 60% decrease in referrals to the ER from the 5 school districts, actually 8, we did in the second year, the 8 school districts that we partnered with. And it was interesting timing. It was 2020 and 2021 where ER visits for behavioral health across the country, in fact, many states declared a state of emergency over it, were on a huge increase. And the districts that we partnered with were on a 60% decrease. Interestingly, we had surveyed the staff totally subjective, saying, what would you have done if you didn't have the partnership? And 60%, actually it was 59% to be exact, said that they would have sent the child to the ER. So it was interesting to see that subjective survey paired up to our, analytical data out of our ER.
I will also say that I think, an important thing about that to know is that now the number is a little different, because we still ask families, what would you have done if this service didn't exist? And the number is lower, but to me, that's promising, indicating that we are getting to students earlier and not just in the crisis. So, the answer often is, I would have waited for an appointment, or I wouldn't have not. The bad answers are, I would not have gotten care for my child. Right, like that's the bad outcomes, but these numbers are really promising and really kind of summarize what we've done. And then I just have some illustrations of the current offerings on the tier 1 level. We do send out newsletters for this is what to the community and to the school professionals, listing the monthly offerings every month that comes. We have, you can't really lead this, but just see how much offerings we have. So this is all the community education, teacher education, professional development, all the different types of sessions. We have well-being sessions for staff, really the entire curriculum for the year. We try to adjust the times so that there's morning sessions, daytime sessions, afternoon sessions, so everybody can find things that they can be available for. And most of the sessions yield CEUs and CTLE credits for the staff, whatever they're eligible for. And then this is our current parent webinars and what the parent newsletter looks like. You do have access to these slides if you want to scan the codes and take a look at the newsletter and the education flyer. It's there. The topics, again, in this series are really wide-reaching topics. It's all about parenting, resilience, academic stress, competition, siblings, how to support student athletes, eating, healthy screen habits, kind of all the parenting topics that are probably on top of mind if you're a parent.
And I'll say a lot of these topics really evolve out of the community interests and asks and needs. So as we meet with the school districts, it's about 2 to 3 times a month. And of course, any of the students that come into the health center, that's where we're really curating those ideas and saying, listen, we have a lot of kids that are struggling with athletic anxiety or high performing concerns or cutting, and then we try to really curate those offerings around what the needs are.
And then these are parent support groups, they're education/support groups for different things. Like you mentioned, anxiety and school avoidance are 2 things that we're seeing a lot of. So we have additional programming for. And then this is our newest resource. We're developing a digital toolkit for parents to have reliable information on a variety of topics, as well as access to different social services, community services, resources, treatment options, kind of reliable information. If you want to, please scan the code and check it out. It's something that we're growing and developing in other languages. And then just samples of our education. I mentioned Project Echo. That was the session today, trauma. Each month we have a different topic, and our 2 upcoming trainings this month we had a big conference actually on election day that we host every year that had over 1,000 participants, and we discussed topics of loneliness, vaping, how to care for students from different backgrounds, online addictions, and gambling. Those were some of the core topics. And then we have the trainings, medication management, paraprofessional training, teacher aid training. Those are the topics this month, just to give a flavor.
Yeah, so just curious if there's board members with questions. Yeah, go ahead, Hillary. Yep.
Thank you for that. That was a lot of information, and it all sounds really good. The one question, and you talked about this a little bit with the HIPAA piece of if a student comes to you, they're then essentially a medical patient, and so then HIPAA applies.
Correct.
Whether they want their clinical data or treatment data released back to the school.
Correct.
I guess my question is also, how does that work? I'm curious about sort of reporting obligations generally with this program in terms of it being a partnership, really 3 ways, right? Between the schools, the child, and the parents. And so I guess one question I have is, for argument's sake, there are concerns at school that they arise at school. The child's referred from the school, and there are concerns that come out through the clinical process that may be related to the home in terms of sort of what then are the obligations in terms of, first of all, like mandating reporting, but also just in terms of, I understand that HIPAA would preclude, if the parents didn't want the school to know, that would preclude that arrangement, but
Correct.
particularly with some of our older students, and obviously this is going to be very different if you're talking about an 8-year-old versus an 18-year-old, or I guess a 17-year-old. If there are things that come out in treatment that maybe a student doesn't want their parent to know, how does that work?
Sure. So I can answer that. So in terms of reporting, so of course we're mandated reporters. So anything that any child reports to me as the physician or any of my colleagues on the healthcare team, we abide by the mandated reporting rules. And if there's any sort of safety concern that would apply, and then those provisions apply. As far as confidentiality for students, so it's it's the same as with any other outpatient provider or therapy provider. We do want the kids to be able to trust and have confidential conversations with their therapists and their doctors to be able to get accurate information and be able to help them and work with them. So we explain to the kids that things are private unless we're concerned about your safety or unless there's concerns and there's things that we really outline for them what are the things that we would have to disclose. Therapeutically, the way we approach it, we usually try to get this explain to the students, this is something I'm going to have to tell your parent or tell your school. We're going to have to talk about it. Let's talk about it together, right? Usually that's what we try to do and discuss it together. But that's the exception from the confidentiality rule. The parents and the guardians do have to consent to treatment. Like we cannot see students without the parents and or guardians consenting for the treatment and bringing them to treatment. So in that sense, again, it's the same as any other outpatient clinic would be, if you will. So it's not any different than that. And we cannot see them without, guardians or parents present.
So if the student sort of self-identifies as needing help and comes to, let's say, somebody trusted at the school and says, I know that this exists and I feel like I need help. Can you assist? And they get then referred to your program. There still needs to be parental consent.
Yes, they would
Correct.
call the parent, not just send
Absolutely.
the patient to us. They would call the parent.
Yeah. If the student is above 18,
Yeah.
they have to consent for themselves, and we have to get their signed releases to talk to anybody about their care.
So anecdotally, I know how hard it is to find help in this area as a parent. Post-COVID, there are very few mental health providers available, and people call and number of doctors, and they hear, I'm not taking any patients, and I've heard many stories about people really struggling to find health care for their kids in this day and age. So I think this is wonderful, and I think super needed. And as far as your timeline, I know that you have found a space in Mount Kisco. What is your timing before you're up and running and have a network in this area and have found the providers who are willing to take kids?
Yes.
So we're looking for a timeline to start this partnership to be summer of 2025. We typically partner with the school districts in the academic year, which is July 1 through June 30th of the following year. So obviously we have some legal and construction things to get through to get to that point, but more importantly, we really do have to have a critical mass. So the way the programs works is that we have a licensed mental health counselor, a child and adolescent board certified licensed psychiatrist, we have an MA, we have a care coordinator, and all of this team. And so what supports the program is the partnerships with the school district. So we do work to have what I like to call a critical mass, but it's scalable, right? So if we only have a few districts signing on, then it'll be a smaller program until we build up to that. For example, when we started our first program on Long Island, it was 5 school districts, and we only had a psychiatrist 10 to 4. And then we added more districts, and then it was 9 to 5, and then we added more, and now we're 8 to 8. And so we can start something before we have that full mass. And then the nice thing is we can continue to grow and add more districts and add more staff. And so our timeline is looking to be July of 2025. That's it.
Yeah,
I feel like
and
we
then
said-
I guess the two things I'll add is that as far as recruitment and as far as identifying partners and providers and where we're going to be linking, we've already started that work, and we're already meeting and talking and kind of getting to know the community and the resources in here, and that will continue all the way through, and that's a continuous process. It never stops. It's why it's really important. We invest a lot of resources into making sure we have up-to-date information, because without that, it doesn't go anywhere. And then with the assessment that we have, and with the fact that, we have the ability to stabilize kids and hold on to them until we are able to find a provider, outpatient providers typically have better capacity to receive kids from us, because again, they've been assessed. So if you're a therapist in the community and you know that this person already saw a child psychiatrist, has a working diagnosis, has some recommendations, you're getting that evaluation assessment, your capacity to take them on tends to be a lot better. So that tends to help. And then the last thing I will say is that concurrent to us working on a school program, We are also working on opening our own practice, child and adolescent psychiatry practice, regular outpatient practice that will be similar to any other clinic, taking certain insurances or most insurances and providing medication management, therapy, and other treatments. And we're hoping that that will also help with some of the access issues as well.
So the idea being that if the school identifies a kid who might need to see someone today, tomorrow,
Yep.
not necessarily critical, like has to go to the emergency room, but just that something's come up
Yep.
and you guys are able to make a same-day appointment
Yep.
or give the parents, enough
Absolutely.
somewhere they can have to go to the emergency
Yep.
room, they could find something happening in an outpatient.
Exactly.
That's great.
the idea.
But even if they do need the emergency room, like, that's hard for anyone, a parent, a school clinician, an administrator, to make that determination, I always joke around, I'm lucky, like, I have Vera on speed dial. Like, I immediately have a child psychiatrist on my phone, but many of us don't. And so that's the opportunity to call the center and say, listen, here's what's going on. We want to make sure we're doing what's the best case. And then if it is, in fact, many times we can see, if the patient is willing and, doesn't need a medical treatment, they can come to the center. And if they do need to go to the ER, then we'll help navigate that process. So it's not like, oh, if it's the ER, we're not involved. Like, we want to be involved in that. We want to help you through the process.
So the school calls the parent in, and then the school and the parent together call you guys and decide what's the next step.
Right.
Right.
Usually in a crisis, that's what happens because it happens same day. A lot of the times, if it's not a crisis, if it's, let's say, we identified that this student has been struggling, they seem withdrawn, they seem like they're not their usual self, we're worried that they might be depressed, they might need to get linked into care, they recommend it to the parent. It's recommended as an option. There's no obligation for the parent to come
Right.
there, right? Like, I think that's really important to highlight in terms of the school's role and responsibility. I mean, this partnership gives dedicated access and a resource. It nowhere in the agreements does it say that you have to send out, and the parents can choose to go anywhere they wish, right? But it's an option, and it's access, and it's immediate response.
Well, I think that's really important too, because I think as a parent, if you find yourself in that situation where you wanted someone to see your kid today,
Yes.
you really don't know what you're supposed to do
Right.
or who you're supposed
Right.
to call. So just
Exactly.
having the option of, here's the center that you could call, or here's 3 names of someone who could see you this
Yep.
week, that would be such a relief for a parent who
Yes.
is finding themselves in a crisis moment as well.
Absolutely.
Right.
And that parent can also call, and now through the hub, we have that clinician support. So if a parent really, requires some clinical guidance and support, does this have to come today, or can I wait until tomorrow? Is it okay? We can get on the phone. We can help support that as well.
Thanks.
First of all, I just want to thank you guys. I think like destigmatization and the normalization of this is like obviously to me even more important than the actual treatment that comes thereafter. I just want to touch on something that Gina, and this sort of like goes to Hillary's point. So there is no recourse on your end if you're getting parental pushback or there's a disconnect between what the parent is feeling about their child and what the child is feeling internally. Like that's sort of out of your hands. Like there's nothing that you can do to sort of intervene if the parent is sort of. And I know
What do you-
I think you
well-
said it was 9% in Long Island, and that number could be even lower.
So
then
in
they
other
don't
words, if
wanna
we make a
connect.
recommendation
Right.
that we say, I don't know, maybe medication we're recommending, which by the way is this very small
Of
percentage,
course.
or that therapy is recommended, if the parent says, thank you, but no thanks, we're not going to do that,
Right.
Your
okay,
hands are
that was
tied.
our recommendation, you chose
Right.
not to take it. What comes into play is the mandated reporting. If there is a
Okay.
concern that the child is in an unsafe environment and might be a harm to themselves, or someone else is harming them, or they could be a harm to others, that's when it has to obviously
Right.
legally be reported.
Or
Put
it's
out there.
medically neglectful. So
Right.
if it
Right.
if it
Okay.
is, if I have a 17-year-old who's severely depressed and
Right.
would benefit from medicine, and their parent is declining medication consent, but I think it's in the best interest of that child, that again we involve.
So you're not helpless in that.
No, we're
circumstance?
not. And I'm as clinician,
Yeah.
I mean, we have whatever protects us as
Okay.
clinicians in any space. I mean, we unfortunately sometimes do have to do that, right? We do
Sure.
involuntarily hospitalize, we go to court for medication over objection, like those are things we sometimes have to do.
Rarely.
Luckily, in child and adolescent psychiatry, it's the exception, not the rule. But we
Great.
do have recourse, yes.
Okay. I think this would be hugely beneficial to any school district, and obviously this is the one that I care mostly about, so
Well, I'll just add that the first center we ever opened was in my hometown because I was super passionate about this, and the second center we ever opened was in Dr. Foyer's hometown. So you can tell it's very personal for us.
They're part of it.
Hi, good evening. I see some familiar faces. So I've been lucky enough to attend 2 of these sessions, information sessions in 2 different spaces, and was privileged enough to attend the gala that was held on November 2nd. It was amazing. And this is the 3rd time I'm hearing, really, and I guess it depends on who's presenting and what your focus is going to be. So I come away with it, from it, thinking about different questions every time, actually, which is amazing. But I just wanted to ask if one of you could actually go over why we would want to avoid the ER, because, in some people's minds, ER is a place where we're going to get help. But in this situation, I think there's a different context to it, so I think it'll be helpful for community members who are not understanding why we want to avoid the ER and what you recommend.
Yeah, sure. And I will say as an introduction that I've spent my last 15 years in the ER as an ER provider, so my love for the ER is deep. But with that love, I also say it's really not conducive to engagement and really helping people in crisis. Sometimes it is necessary. There are families, there are kids that really do need that environment. The emergency department, first of all, what emergency departments you end up in and what kind of provider you're gonna see, what kind of expertise you're gonna find, what kind of resources and environment you're gonna find varies greatly between hospital to hospital. That's true across the country. Even if you end up in a place that has child and adolescent psychiatry expertise and a dedicated space and a dedicated team and best case scenario, even then, it's a highly restrictive environment. It's an environment where we have safety regulations that we have to manage patients in a way. For example, we have to have them change out of their street clothes, we have to take their belongings, we have to take their phone for privacy concerns, so that they can't take patients and recordings of each other, things like that. Typically for example, in the Children's Hospital ER, it's a locked care space, which again is as child-friendly as ERs go, but still, it's an environment where you have a camera, where you have unique furniture, unique door handles, glass on the doors, very little privacy because of safety concerns. And it is a difficult environment to be in. Also, in addition, in emergency rooms, inherent in the nature of it's not a scheduled appointment and we have no control over who comes through the door. There often are delays, wait times. It's a process whereby you have to see a nursing team, you have to see a medical team, you have to see a behavioral health team, a social work team, potentially a very lengthy process. So all of that can really be active to what we're trying to achieve, which is erase stigma, make people feel comfortable, feel like they're handled the same as like if they came with any other medical problem, and engage them in that process that initially can be so very scary and intimidating, and often yields, especially for kids, an experience whereby they say, I'm never telling anybody anything ever again, because look what happened. And that's what we want to avoid. And we'll direct schools to send kids to the ER if they really need it. It's like if a child's not in good behavioral control, if they're already hurting themselves, if we need a medical assessment, if we need lab work, if we need head imaging, if we need certain things, they need to go to the hospital. But even then, we can help support that process and navigate it, which is helpful because it's very chaotic.
Right, and I think one thing I would bring up again was something that I learned through one of your sessions, was a learning moment for me, was that when we think about mental health services, we usually, I'm not speaking on behalf of everyone, but I think the case is that we think about tweens and teens. We think about children who are a little bit older having these issues, but it really can be students as young as 6, 7, or even younger. And when we think about it in that context, where they would have to be in an ER waiting room or in the hall with other people that are in need of emergency services, I think it highlights a different urgency and a different level of care.
It's not the best introduction to mental health care is
Right.
in the ER. If
Right.
it's necessary, by all means, you need to be there, but the vast majority, that's not, you're accessing the ER because there's no other way to access care.
Right.
There
Thank
is an
you.
increase in younger kids in general in the past several years.
sure the
There is
school
an
district could
increasing
confirm
number
that,
of
yeah.
kids presenting younger and younger.
The other question I had was, in this consortium of school districts that you are trying to rally together to launch this program in this area, is there a number that you are looking for, whether in terms of actual school district versus the number of students that will be in these services? Because
Yeah.
is there sort of like, I know you mentioned we can start off with a low number and then we'll staff by need.
Yeah.
But there must be a number that you're working with.
Yeah, I mean, again, we can get creative with our options, but if I had to say, like, what's a typical number we start with, it's not really by school district, because as you know, school districts vary greatly by size. I mean, on Long Island, we have some school districts that are 15,000 students, and some that are 1,000. So it really is kind of by number of students enrolled in the district. So it's a perfect world, it'd be like 20,000. So whatever makeup that is, if it's 10 small little districts of 2,000, or a smaller number of larger districts.
So number of students enrolled per district to add up to 20.
It's enrolled in the district, yeah, that's how we go.
Not the number of students that will be using the service, because you don't
No,
know that.
there'd be
right?
no way of telling
Right,
that.
right.
Yeah.
Enrolled students.
Right.
Yeah.
So that's not.
Because access is unlimited.
And remember, we're not just, our partnership isn't just about access for those students, but the professional development, the community education. So the larger the school district, the more schools, the more faculty that we support, the more community families we support. So,
Okay, so then I guess I think it's my last question, is what are the challenges and what are the hurdles that you foresee in the future? Because with every good thing that you're trying to get launched, there's always going to be some type of political issue, some hurdle, some challenge, some competition feeling, like, we have BOCES that is very sensitive.
so our goal is to partner with BOCES. We've met with both Putnam, Northern Westchester BOCES and Southern Westchester BOCES. Like our preference is to partner with BOCES, and there should be no competition, because it's really, we want our services to start where their services end, and the same with the school districts. They're wonderful clinicians within all of the school districts we've worked with, and our goal is to build upon their skill set, not to replace it.
But the challenge is, I think it is fair to say that connecting to care and like how well we can build that network and how we can keep that up and what kind of connections we make is going to be, and it always is. It's the constant challenge. It's probably one of the heaviest lifts in all of this is the care coordination. So that will be, and then just, being able to adapt to the community. I think, I don't necessarily think that's a challenge that we're not going to overcome. I mean, we have a track record of being really collaborative and building this program based on the needs of the districts, and we're ready and open and ready to learn about what those needs are going to be in this community.
So I lied, I do have another question. I have actually two more. So that reminded me, so I remember being in one of the sessions, I think, I forgot who was presenting. There was something mentioned about the first year being at no cost. Is this still true?
So that's the current year where we are making our preventive services and our tier 1 offerings available to the districts, and
So just a tier 1 offering?
Right.
that
That
is the
professional development,
current
community
this
education.
year offering, yes.
Okay, so this year from meaning July of 2025?
Right.
start.
Until June,
Until July
June
2025.
of 2025.
2025.
July 1 would start the new academic year, where we hope to open the behavioral health center. So that's just for the tier 1.
July 1 of 2024 to next year.
Right,
June
correct.
2025, July 1,
Right.
Correct, and have access to the brick and mortar.
Wait, so
Tier 3.
Christine, say that again?
So right
saying
now,
we're
the
starting
the
earlier.
year that's free is the current
Now.
academic year. We have access to PD if we'd like to use it. Next year, we would be paying for the service.
Okay,
through
so
BOCES.
the clock already started, but we're not taking advantage of it yet.
Some
because we're
schools
not
have,
really-
we have for some schools,
Okay.
yes.
And I
yeah.
think to your district too, I think we shared the schedules and so whenever you
You're welcome to
guys
sign up.
want to review and share that with the community, you know, and provided a link to submit requests for presentations as well, if you guys are interested in that, that can start.
July of 2020, oh man, I feel like we need to get like prorated because I didn't know that. I didn't understand that in the first 2 sessions I attended. Okay, so then when you talked about your meeting with the school district 2 to 3 times a month, who is in those conversations?
So that really varies district to district. We do invite, we ask each district to provide us with a list of who they would like invited. Some districts only include their clinicians and their clinical team members, and some include their building principals and administrators. And we have high school principals that come religiously to every meeting. They obviously feel like they benefit from it because they do come regularly. So it really is up to the district as to who attends. You know, typically the clinical staff and the PPS leaders, and sometimes other school leadership.
Okay, great. Okay, thank you.
I think most of my questions were already asked, except for one, which is based on the fact that you've kind of done a ramp up over a few years with a bunch of school districts, you've undoubtedly learned what school districts need to do to get ready and to do a good job
Yes.
partnering with you.
Yes.
So I'd like to hear some of your reflections about how we can take the most advantage of what you're offering.
I mean, I think the heaviest lift with every district and the most successful school districts are the ones that do it really well is awareness about the program on every level of the school. So to make sure that every member of the community is not only aware that it exists, but gets continuously updated about what's offered, because we see that districts that do that well really utilize the services and parents are logging in. We do provide our districts with a dashboard and data about how the services are utilized, all de-identified, but up to, you know, how many sessions are parents coming to, how many sessions is your staff coming to, things like that. And that's what we see, is that when the communication is clear, consistent, and usually districts are successful in that when they communicate in multiple channels. So when they're sending emails, posting on social, putting on their website, updating, inviting us to meetings, getting us connected with the PTA, staying connected to the board, coming back to present on the results, staying engaged. So really that's, I think, the crucial component. And then looking at as an opportunity to get expertise and collaboration and utilizing it.
Gina, anything more to add?
No, I mean, I would just say from like the background of it all is like we work very closely with the BOCES, so we know also how to guide the BOCES on like how to like what type of COSUR that they apply for, and working closely with their lawyers, and we try to really put them in connection with the BOCES that we have on Long Island that have already done it to help expedite them through the process. And we're also happy to connect any of the Westchester superintendents or PPS directors with their colleagues and counterparts on Long Island to help say, hey, what's worked for you really well. Admittedly, my home district does not send out the information as well, and it kills me. We do have a change in assistant and superintendent, so I'm hoping that gets better. Whereas Dr. Foria's home district, she gets every single newsletter, every single thing. So it really is how well that school district, you know, can communicate that information.
They do have one of the highest attendance rates
Yeah.
at the sessions also, and they have the highest attendance rate in all.
Yeah.
I think I'm hearing a challenge.
Wow.
I think
Mine
I'm
does
hearing a
not.
challenge right here.
Yeah.
For sure.
So just one, sorry, Christine. So just one more question. If students are being referred or they're going in themselves, you are providing, you're guaranteeing a connection to a mental health provider at that moment, even if it's not deemed a crisis, because I don't know what your rubric for identifying crisis to be,
Yeah.
but usually when a student or a child is in need of something, to them, to the person that's going
course.
through
Yeah.
it, it's a crisis.
Anyone who calls us and says they need an appointment with the behavioral health center, we're going to do a quick intake, what's going on to help us determine when. Is it like right now or could it be next Tuesday, But everyone will get an appointment if they call and say, I need to see somebody, I don't know what to do,
But not
for
like
whatever
next
reason.
month.
No, everybody, routine cases
Unless-
get scheduled within a week and.
Unless it's the
crisis
parent's
same day.
availability, which often a parent may call and say, I know I need care, it's not a crisis, I'm
Sometimes,
going
yeah.
to, on a
I'm
work,
going to be off on Veterans Day,
you know,
can become that.
can we come
Yeah.
then? So, yeah.
Which happens, yeah.
So thank you for coming. We really appreciate you being here today and taking this step in terms of not only our education and awareness of the program, but I am planning to send this out, which was one of the reasons why we videotaped and started early, to my colleagues, because what this allows us to do is have a mental health clinic for our children and for our staff as a resource, and expands our footprint of care for our kids in a way that is unparalleled. And I can't underscore the importance of the partnership between the school districts in Long Island and Northwell Health, and the amount of opportunities for care that didn't exist before that partnership was in place. And our BOCES has agreed to offer a COSER for us to be able to support the financial aspect of this as we move forward and we budget. I don't know if Josh, if you wanted to talk a little bit about that.
Yeah, so I spoke to Nassau BOCES and our BOCES, and this would be aidable at our regular 0.67 rate, which would come out to about 41 to 51% aidable. And they did a comparison of like school districts and size of ours on Long Island to see what they were getting back, and they were getting back between 40 and 50% from the state on this service.
So for us, we plan to plan forward and think about this in terms of our budgeting process for our BOCES services for next year. And then I'm going to continue to create awareness around the region, and hopefully more school districts will consider this partnership as well as they become more knowledgeable about the program. And I do want to thank our colleagues for being here this evening and for answering any of our board's questions. And if there's any additional questions after tonight, I can certainly share them and get those answers for you as well.
Thank you.
guys.
Thank you for having us.
Guys, thanks for having me.
Or we're just going to transition for a second to the elementary.
Right. So, okay, so we're going to do elementary next because we have young people in the hallway and we want them to be able to go home. So we're going to go there, but they're going to come in and say something first, I think. Or someone on their behalf is going to say something first.
Ryan, may I? All right, we have to get started right away because we have a lot of little people in L building with their parents. And so before I introduce Debbie, who's going to begin our presentation this evening, I just want to invite our audience to L building when we transition. There's plenty of space in there. We have our parents already in those spaces with our kids because we want to make this an experience that anyone can enjoy that would like to be there. And this year, the board has asked that our schools present different aspects of their program by level. So this is a different model this year, which is great. So our elementary level is going to highlight 3 different opportunities for us to learn about what's happening in their spaces. And so Debbie's going to begin by talking about our performing arts program.
Good evening, everyone. Grafflin is so excited to be here this evening to present Performing Arts and Visual Arts. So our art classes at Grafflin Elementary play a very vital role in fostering creativity, critical thinking, problem-solving skills, and collaboration. In a very supportive learning environment, students are encouraged to express themselves, explore their individuality, and collaborate on hands-on projects. Our art classes provide meaningful experiences that help students view the world through different perspectives and connect with global cultures past and present. Our music program enriches learning by developing students' musical skills and appreciation, enhancing memory, focus, and supporting language development. It offers students an outlet for self-expression.
Grafflin's art projects and music performances are designed to connect with core subjects such as literacy, social studies, science, and the building's equity initiatives, providing K-4 students with a comprehensive, integrated learning experience that broadens their understanding of the world. Through the arts, students find inspiration to imagine and consider the future while growing as well-rounded individuals. Engaging in visual and performing arts nurtures their creativity and supports both their academic and personal development.
Debbie, do you want to share what the board will be experiencing when we transition into L building?
So this evening, the children for music class will be doing rhythms and rhythm instruments, and they're going to teach you all about the rhythms, and also that it's a K-4 program, and that they eventually will use that knowledge to join band and orchestra. And then in art class, there's a connection of literacy by reading a book, and they're going to teach you all about pointism, and they're going to actually get you started on an art project. So they're going to teach you both music and art this evening.
Thank you. And then Alyssa, would you like to talk about our phonics lesson that will be?
I would. So this evening, you are going to have the opportunity to not only see, but we hope you will participate in a kindergarten phonemic awareness lesson from the Hegarty curriculum. So at the last board meeting, there was a question about what is phonemic awareness and how is it different than phonics? So our kindergartners thought, what better way to answer that question than to show you? So before we go in, we'll give you a little bit of a primer. So phonological awareness is the ability to recognize and manipulate the sounds in spoken language, and spoken being the key word there. Phonological awareness works along a continuum, the most sophisticated along that pathway being phonemic awareness. And phonemic awareness is the ability to identify and manipulate individual sounds in words. Phonics is then when kids learn how those sounds are represented by letters in written print. So phonological awareness and phonics work in tandem for kids to become skillful readers and writers. So tonight, when you're engaging in this lesson, a skill you're going to practice is segmentation. When you can segment the sounds in words, and then you know the letters that make those sounds, you can spell. You're also going to practice blending this evening. When you can blend sounds auditorily, then when you go to read a book, you can blend the sounds in a written word if you know the letter sounds. So one thing you'll also see in the Hegarty lesson is there is a component where students are identifying and practicing basic letter sounds. So that is a phonics skill being practiced even within this phonological awareness program. So the lessons themselves are 10 to 12-minute daily lessons. They're systematic, they're sequential. There is a multi-sensory and tactile piece, which gives an entry point for every child and reinforces the learning. And one of our classes even brought their Hegarty mascot, Heggy, with them, which gets awarded to the most outstanding performer this evening.
Oh, who's going to get that? Okay, and then Tanya, would you like to share what Roaring Brook will be presenting? All right.
So good evening, everyone. Tonight you will see students role play a DBT session. So dialectical behavior therapy, DBT, is a therapeutic approach that helps individuals develop skills in 4 key areas: mindfulness, emotional regulation, distress tolerance, and interpersonal effectiveness. While DBT is often used in clinical settings, its core principles can be effectively integrated into a school community to support students in managing emotions. I can't see, sorry. Building resilience and improving social interactions. DBT is most effective when anchored in a strong, positive behavioral interventions and supports, or PBIS program. PBIS is a framework that promotes positive behaviors, emphasizes proactive strategies for teaching appropriate behaviors, and creates a school climate where students feel safe, valued, and understood. So by embedding these 2 things together, PBIS, into the school fabric, along with DBT, it's a nice net for our students to feel safe and to feel empowered in the school during their school day. At RBS, we have the Ring program that sort of is our PBS program, and it works in conjunction with DBT.
Thank you, Tanya. So what we plan to do is we will go to kindergarten first, because it's going to be released. Once you guys meet with them, they'll head home. So we're going to go to kindergarten at West Orchard, and then we're going to go to Grafflin, and then we'll go to Roaring Brook, but we're all in the same spot, which is Upper L. So we, again, would like to invite the audience to come with us, and then Debbie, if you could, no, Alyssa, if you can lead the way to your space, that would be great.
We have Ms. Jenna Big and Ms. Karagiozzi, two of our kindergarten teachers with us this evening, and 6 of our incredible kindergartners who are ready to be integrity teachers. Let them begin. All right, my friends, are you ready for rhyme time? Yeah. Awesome. I'm going to say a word, and you need to tell me which word rhymes with that. Are you ready? Which word rhymes with which? Mat or dish? Dish. Good job. What word rhymes with math? Pass or pad? Pad. What word rhymes with that? Sat or pin? Remember, rhyming words have the same middle and ending sound. So, and sat. What word rhymes with shop? Bed or shop? Job. All right, last one of rhyme time. What word rhymes with think? Blink or fold? Blink. So how's that? Is that right? Amazing job listening. All right, friends, now we're going to get our choppers up. Can you show me your choppers? So I'm going to say a word, and our job is going to be to chop off the first sound we hear in that word. And that first sound is going to be a vowel sound. So you're going to say my word and then chop the first sound. Ready? Ox. Excellent. Next one. Object. I. Last one. It's. There's a paragraph. Is that right? We're going to keep our choppers up, and instead of chopping off the first sound, we are going to break apart a word into 2 sounds and then blend it together. Are you ready? So we're going to chop off the first sound and then the rest of the word. Here's your first one. Ready? Ox. 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 Good. Next one. Eve. Next one. It. It. Good job. What? Oh. Oh. Whoa. Last one. Eat. Beautiful jobs. Now keep those choppers up. Instead of blending them, we are going to chop off the last sound you hear in the word, the final sound. This time I'm going to give you 2 words that have the same ending sound. You're going to say those words and chop off the last sound. Are you ready? You're doing such a great job. Here we go. Ready? Tub, cube. Tub, cube. Good job chopping that ending sound. Next one. Black, pit. Black, pit. Good. Next one. Bud, hide. Bud, hide. Good. Next one. Tuft, light. Tuft, light. Just reading off the script. Next one, you're doing great. Wag, tug. Good. Last one. Edge, wage. Amazing. Give yourself a pat on that. Is that right? Now we're going to keep our choppers up again. And now we're going to say the whole word first, and then we're going to chop it into 2 parts. The first sound, and then the rest of the word. You ready? So keep those choppers up. Your first word is line. Line. Oh, good job. Next one. Did. Good. Next one. Food. Food. Not. Next one. Rope. Rope. Last one. Mail. All right, my friends, now we are going to listen to a word part, and then I'm going to give you a beginning sound that we're going to add to the word to make up a new word. Are you ready? Say it. Add. It. Good. Say it. Add. Say it. Add. Say it. At say it. At okay, now I'm going to give you a word, and we are going to take away the beginning sound, and you're going to tell me what's left. Are you ready? Say dip without d. Good listening. That's tricky. Say hip without it. Say sit without s. Say lip without it. Say dip without it. Good job. Okay, now I'm going to give you a word. We are going to change the first sound of the word to make a brand new word. Are you ready? Say fin. Change buck to fin. Say fin. Change to tin. Say tin. Change to pin. Say pin. Change to what? Win. Say win. Change what to pin. Nice listening. All right. Now we're going to review some letters and I'm not going to help you. You have to do this on your own. Ready? First sound and letter. K. Eat. You up. Need us. H. O. R. R. Seek. L. The last part of our Haggerty lesson is a nursery rhyme. So I'm going to sing the nursery rhyme, and you can sing along with me if you know it. But while we're singing, I want you to listen to the rhyming words. Are you ready? Okay. So make me sing along. Mary had a little lamb. You ready? Mary had a little lamb. Its fleece was white as snow. And everywhere that Mary went, the lamb was sure to go. What rhyming words did you hear in that autumn? Snow, snow and go rhyme. Good job. Okay, hold on. Have you noticed a lot of really good things during our lesson? We saw a lot of good listening. We heard a lot of sounds. There was one person here that did a superb job that we want to call out. Ready?
So I'd like to introduce Grafton's music teacher, Mrs. Bar, and our fourth grade students are here, and they've got some rhythm instrument, and they're teaching about rhythm, and they're also going to talk about also that's referring to the Angela as well. So Mr. Listigar, it's all yours for the next few minutes.
Okay, it's actually all yours. Take it away.
Welcome, friends. We're going to be teaching you about rhythm. But first things first, can anyone spell rhythm?
Anyone who can spell rhythm? Anyone?
R-H-Y-T-H.
Oh, cool.
That's the reason I wasn't in the song.
Now it's down to business. The quarter note is not very exciting, but it is important. It is called a quarter note because it takes four of them to fill a measure. We're going to be adding an ostinato note. This is when the rhythm is repeated over and over again, but we are now going to add a whole note played by a drum. It's called a whole note because one note lasts for the whole measure. This will help us keep track of where beat number one.
Now let's put 8 together. The 8 points as fast, so you heard 8 in the measure. Once again, the drum will be playing the whole notes.
How about 16 notes? You guessed it, they're so fast that 16 of them fit in a measure.
Now let's have some fun. Let's combine different notes. To me, that kind of sounds like I love huckleberry pie. How about you? I love huckleberry pie. I love huckleberry pie. I love huckleberry pie. I love huckleberry pie. How about another one? I hear those notes saying happy dog, happy cat. 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 Let's keep it going. Hey, let's not forget about the rest. Sometimes you get silent. That sounds like everyone is here. Let's have fun. Here, let's have fun. Everyone is here, let's have fun. Everyone is here, let's have fun. Everyone is here, let's have fun. Hey, let's not forget about the rest. Sometimes you need silence. This one must be saying quiet. Please. Please, quiet. Please, quiet. Please, quiet. Please. Okay, last one. That sounded like grape, cherry, watermelon. 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 Now it's your turn. Please accept an instrument so I can join in on the fun.
That's your big break. Oh, thank you. Oh.
You might hang your legs on the board. You may then repeat after us. But please, stay on the beat.
All right, there you go. You are hired. I'm pretty good at that. Thank you so much. And we're going to transition straight to the visual arts.
We're going to teach you all about their arts and their job.
What can you do with the dot? A lot! This is Sunday on the island, John. I'm going throughout. It is made a tiny dot. Actually, throughout which means rental of artists think about composition. What is composition? Anybody know? It's where you place things on the page. In art, we read the dot. In the book, Bostry can't think of anything to draw. Her art teacher tells her to make a mark and see where it takes her. She makes lots and lots of dots. She even makes a dot by using negative space. Grown-ups, here's your challenge. Create a piece of artwork by only dots or circles. Think about your composition. Use symmetrical or asymmetrical bounds.
What does that mean?
It means if symmetrical means each side is the same, and asymmetrical means one side is different from the other side.
Thank you.
Contrasted with it. Will you have repetition or pattern in your work?
Most importantly, I'd like to invite you to actually go ahead and make some artwork. We have the background here. These are the background pieces, and the square pieces over here to be cut up into circles.
And don't forget to write your name.
Yeah,
don't forget to write your name. Can I help you?
I'm gonna write my name first so I don't forget.
Oh, they have. Remember to write your name. That's your. I think my dad forgot.
It don't have to be a perfect circle, but that's part of it.
Yeah. You can do a Bible, you can do circles, you can do quarters, you can do how we make it. Oh my God. We get a piece of paper. Erase some. Some. Oh, they already did chop and then. Yeah, I know the rules. I didn't want to. And Luca, you have the name and there's your circle. Push it. Wow. Love a vision. What's your vision? A vision is a vision. Yeah, you don't need for you to make a circle three-dimensional.
No, I don't know. Oh my God, that sounds hard.
It's actually kind of easy.
Regular circle.
Oh.
What did you do? It was the trim. Can you give me a strategy again?
What do you think I should?
You don't have to use it. You don't have to use it.
You think I could put like different colors on the side?
So don't let my hands go, just keep going.
9. You could also make a circle inside. Yeah. Oh, you could do a circle. Oh, even a circle in it. Like if you made a spiral like this.
That's so much.
Would you?
Yeah, my kids.
Yeah.
Oh,
Nice.
I barely got it.
Underpants.
Yeah.
Size or color. Like for one time, you have black piece of paper.
Yes, I did.
But that so this is my new folder.
When would you want to do
I did. I put him on the front.
Yeah. So I tried to do.
Do you write your name on the back? No.
There on the phone, is that okay? And I tried to put another one there. So I wanted you kind of like into it. Is it like? Yeah. Yeah. Does it hypnotize you if I like spin it?
I can hypnotize it.
All right, it's time to go for
You have an exception. You want to do this? You can keep it.
It comes out, it's smoothly. Yeah, it comes out of everything.
It's chopped up? No, I can't. Hard to be on the
little bit calmer so that they don't get too big. Okay? The next part that we're going to talk about is mindfulness. Daniel, can you tell us what mindfulness means?
Stay calm.
To stay calm. Does anyone want to add anything on to that? What should you focus on if you're being mindful? What should you focus on? You should focus on your teacher. Yeah, being mindful means thinking about just what's going on right now, right? Not the feelings I heard. And then the third part is called distress tolerance. And this is when you do have a big feeling, what you can do to deal with it, to cope with it, right? Okay. So let's do our first activity. We have this bowl that has a piece of paper in it, and on each piece of paper is a feeling. So you're going to choose a piece of paper. With that, oh, one jumped out actually. You don't want you going for it? Okay. You can unfold it. Did you? It's a good one. Okay, so you can open up your paper. Take a look at what you have. Gabriel, what do you have? Excited. Ooh, is that a comfortable or uncomfortable feeling? What do you think? Gabriel thinks it's comfortable. Daniel, what do you think? Amelia thinks it's comfortable. Can you think of a time when you felt really excited? Birthday party. A birthday party is a time you might feel excited. Gabriel, did you have another one in mind? Yeah. What is it? Do you want to share?
When I was about to have my first play date with one of my friends.
The first time you didn't have a play date with a friend, you felt excited. I love it. Amelia, what did you? Oh, she got sad. Comfortable or uncomfortable? What do you think? Gabriel thinks uncomfortable. Daniel, what do you think? Daniel thinks sort of in the middle. Amelia, you think uncomfortable? Can anyone think of a time that they felt sad? What do you think?
When my best friend Robert had to
when a friend had to move away, right?
Oh yeah.
Yeah, you might miss that friend. That might feel sad. Daniel, what did you choose?
Like those.
Well, Daniel's showing us with his face. He got mad. Is mad comfortable or uncomfortable?
Very uncomfortable.
Very uncomfortable? Okay, Daniel, can you think of something that's made you mad?
Like
when my parents ask me to do homework.
When your parents ask you to do homework, when you have to do something you don't want to do, you might feel mad. So let's look at these situations. Oh, Robert, you're connecting here. You just, not Robert, I'm sorry. Gabriel, you're connecting here. You just found out that your best friend is moving to another town. How do you think you would feel? You told us a little bit. How do you think you would feel? How did you feel?
So if your friend had to leave, I think you would feel sad because
What do you think?
if they left, that means there would be a way bigger chance of you not getting to see each other.
Maybe you wouldn't get to see each other so much. You might miss each other. Right? Thanks for sharing. Ooh, here's another one. Ready, Daniel? Worked very hard on an art project. When you brought it home, your little brother destroyed it.
Or sister.
Or little sister. Amelia, how do you think you might feel? Oh, two feelings. Two feelings. Sad and mad.
That's the most recognizable one. Frustrated.
Oh, frustrated. Daniel, tell them what frustrated means. What does frustrated mean?
Frustrated means that you did something, but you worked hard on something, but it got destroyed or something bad happened to it. Then you had to do it all over again. It's frustrating.
It's frustrating. Yeah, frustrated is when something does not go the way you want it, right? You did not want your little brother or sister to destroy your art project.
Thank God I don't
right?
have one.
So now we're going to move on to mindfulness. And one part of mindfulness, one thing that you can do is something called mindful breathing. And you see up here, there are two steps. Smell the flower, blow out the candle. Look at the paper you have in front of you. And it has a picture to help you. Smell the flower. This flower doesn't actually smell, it's just a picture, but we can pretend. Blow out the birthday candle. So let's practice. Let's do this twice. When you're smelling a flower, you're using your nose. So the air is coming in through your nose. Ready? And then when you're blowing out the birthday candle, coming out your mouth. Hard as you can. Ready? Do it again. Blow it out really hard. Nice. Good job.
Speaking of birthday candles, it's almost my birthday.
Wow. And you're really excited about that, aren't you? Definitely. Okay. So the next thing that we're going to talk about is something called distress tolerance. And this is when you have a really big feeling, because sometimes feelings do get big and we have to deal with them, right? You want to try to push it out of your brain. Sometimes it's a little tricky to do. So here we're going to talk about something called a grounding technique. And we're going to count down. I'm going to give you another example here. Okay. And we're going to try to find things in this room to help us ground. So the first one is 5, and we're looking for trying to find 5 things you can see around you. I see Gabriel's eyes looking around. You're using your eyes to try to find 5 things you can see. When you've found 5 things, give a thumbs up, a silent thumbs up. Amelia, what's one thing you noticed that you can see? The bowl in front of you. You noticed it. Gabriel, what's one thing you noticed? The expo markers. Wow. Daniel, what did you notice?
My dad,
Your dad.
Dr. Ackerman, and
Daniel, you noticed a lot of things. Okay, so let's jump down here now. 4 things you can feel. Use your hands. Use your hands. Try to find at least 2 things right now that you can feel. And give a thumbs up when you noticed them, when you found them. Daniel, what's one thing that you felt?
First of all, the table.
The table. What? Hold on. What do you notice about the table?
It's
hard or soft?
Soft.
The table's soft?
Hard.
It's hard. It's smooth, right? But it's pretty hard.
Yeah, because rough is hard. That made me confused. Also, my hair.
You felt your hair. Sure, that's wonderful because that's always with you. So that's something you can feel.
After
Sure.
my pen.
And your business. That's great. Let's come down to number 3 here. This page has an ear. This page has headphones. Either one gives us a clue. 3 things that you can hear. There's something, Gabriel, what can you hear?
So I just heard laughing.
You just heard laughing.
I heard you walking.
You heard my shoes.
And I heard you talking.
Wow. You did find 3.
I heard people laugh. I heard them laughing, you talking, and the background fan over there. Look here
It's
closely.
really good listening. I like how if you close your eyes, sometimes you can hear more things, right? You focused in. 2 things that you can smell. And one thing that you might like to taste. Amelia, what's something that you can think of that you like to taste? Candy. I love it. Gabriel, what's something you like?
Hot dog.
Daniel, what's something you like?
Burger. A McDonald's cheeseburger.
McDonald's cheeseburger. So when you think of it, you can almost, your mouth can almost start to taste what that tastes like, right?
Like I know a lot of people have been to McDonald's recently because of the cross there.
Oh, really?
Yeah, the Happy Meal.
The Happy Meal. So when you do these things, when you go through this list, it can help when you're having a really big meal because it helps your brain to focus on other things. All right, so we're going to wrap up now. We have 3 kind of questions or prompts that we're going to think about. One thing I learned today that will help me when I feel upset. What's something that you think you might be able to try? Oh, the grounding. Is there one that really sticks with you? Is it the see, the feel, the hear, the smell, or the taste? The smell. You're not going to forget that one. You'll remember that.
Smell and blow out the candle.
Oh, Daniel, you're connecting with this one. Blow out the candle. I love it. A feeling I want to work on. That you'd like to work on? You'd like to work on having
Green zone.
Oh, Daniel's talking about the mood meter from Ruler.
Green and yellow.
And yeah, green and yellow are the more comfortable parts. Are you raising your hand or you're stretching? You're stretching. Okay. A coping skill I want to try is coping skill I want to try. And remember, we talked a little bit earlier. We have talked about some coping skills that we have in our toolbox for big feelings too, right? Take a break, draw or read, talk to a trusted adult. So what's a coping skill that you think you might want to try? Notice one that you might like to try? You have any big feelings?
Probably. I think the coping skill. Breath.
The deep breaths, yeah. You like using deep breaths, right? That's great. And when you hold it too, it can help to take a deep breath. Deep breath.
I think it would help me sometimes if I did some
Yoga. I love that. That's a great coping skill. Thanks for sharing. Any questions? Thank you so much.
It was so amazing to hear your stories. To learn with you this evening, one more round of applause. That's good. Thank you, Jen. We could be
If we're all back together, we'll go to the president's report now. We're a little out of order today, but I still have my, typical gratitude to offer to everybody in the district. I have quite a list this time, actually, so I'm going to try to get through that quickly. public service announcement. We haven't talked about the arts as much in some of this gratitude, but we do have Little Women coming soon. So if you haven't gone to the to Greeley Theater, there's a great opportunity to do so coming up. Little PSA, appreciate everybody that's committed to the theater program here at Greeley. Also want to give a shout out to the Scholarship Fund for hosting the Spelling Bee recently and acknowledge the superior competitors that are here in the room with us tonight. Lisa and Christine both coming through. I love that.
Team,
I love the modeling at the top, that's going on here with, instructional leadership when it comes to spelling. So appreciate you for that. Also, I had a chance to go to the cum laude ceremony last week for all the seniors. Great to see such a big group of people young people who have achieved so much with their academics and being recognized for that. And fall sports have wrapped up, and we've got like a whole list of awesome sports teams. So everything from the tennis state title to volleyball, football, field hockey, soccer, go down the list. So just, again, really appreciate our coaching, athletic director, all the parents that are getting all of these kids everywhere they've got to go, and keeping their academics going at the same time. So that's my long list of gratitude for this week. I don't need to do an agenda preview because we've already done a lot of it. The hospital, the elementary, and there's going to be a lot of contracts here coming up. So over to Dr. Everman.
Thank you, Ryan. And so a lot of our community update is actually on the agenda. So I'm going to have Josh begin by talking about some change orders and the capital project and some of the resolutions that you see tonight before you.
Sure. So on the agenda, there are change orders for our capital project. These are items that were discussed in our facilities committee. On the left is change orders at Roaring Brook around additional asbestos abatement that was needed and additional electrical work. Some of you will see that there's a new pole in the Roaring Brook parking lot. In order to bring in the HVAC, we had to bring the electric up to code, and that involved putting in 2 new electric poles on our property. So there is a change order for that work, and that includes all of the electrical and contractual work. There's also a change order for the Roaring Brook ceiling, and there's no increase to the purchase order. This was because when they were doing the roof at Roaring Brook, there was a storm and the roofing contractor did not protect the ceiling well enough. So they had to replace the entire ceiling of the Roaring Brook gym. So it's a change order. However, the roofing contractor has agreed to pay for the ceiling that was damaged. The next is, in the last board meeting, you had approved an RFP for our technology services. So Andrew Taylor presented last year that we were going to be shifting a significant amount of our technology services with our current company, Acture, that we've been with for over 20 years, to BOCES so that we receive state aid on the work that we have in district. So the left side is the contractual portion that we cannot get BOCES aid on. So we have a contract with the district for an audiovisual technician and a level 1 help desk. And then on the right side is our normal Acture services, which has listed out everybody that we worked for Acture that works in our district. And that is, we now receive 65.9% aid on that. So next year we'll get a little over $700,000 back on the work that does. This has been work that we've been working with BOCES to take on this service for over 5 years so that they could take this contract so that we could receive aid on our technology services that we have. So that's a budget transfer from the technology department to the BOCES line that you would see on the agenda. And then the next is really exciting. The next phase of our capital project, we're approving 5 separate contract bid awards for the athletic pavilion and bathrooms, the J Bridge replacement, and the 7 Bridges modified baseball field and fencing, totaling about $3.1 million. We are right at to a little under budget on our capital project. We just opened the final HVAC bids and we're interviewing those companies next week. And we have determined that we are able to do everything within our budget in the capital project now that we have all of our bids back. So this is work we're hoping to start as soon as possible so that we have a schedule for it that's not disruptive to our schools. So the athletic pavilion and bathrooms, as football season ends, as other sports wind down for the fall, we're going to be able to start construction on the pavilion and the bathrooms out by the football field.
Thank you, Josh. And now we're going to transition over to Adam to explain our Insta grants on the agenda.
Thank you. So we have 3 CSF grants on the agenda. 5.17 is to expand the percussion program at Greeley, put in by the Greeley band director. So that's going to give us a capability to add some new instruments and percussion for the students here at Greeley. The second one is a grant from Seven Bridges around biophilic design. I actually had to do a little research on this one to learn a little bit more about it. This is about integrating plant life in built spaces and architecture. So the grant is kind of an interdisciplinary grant with school psychologists, STEAM, science department, et cetera, where they're going to integrate more plant life at Seven Bridges. So that's kind of a neat, exciting grant. Hopefully it'll expand into the other schools. And then the last one is for some recording equipment for Bell. Our world language teachers over at Bell have struggled with some of the background noises. The students have recorded various, world language kind of practice. And so this is a collaboration between our STEAM teacher, Warren Whitney, and Caitlin Murphy in the world language department so that the students can create audio, visual with like lapel mics and things like that. So those are the 3 that are on the agenda, and thanks to the CSF for those grants.
Okay, and I'm going to describe the PTA grant that's on the agenda tonight. So from our past conversations, this is the first year that we've had a debate team where we're looking at it in the same through the same lens as an athletic team. And so we have 60 participants, which is great. We have a coach, and there are debates that our coach is taking our students to throughout the region, just like we were in athletics. But we also have members of the debate team who there's different styles of debate. And so we have a pocket of kids that would like to participate in this different style. And so to do that, it's normally not a problem. We certify that they go to school here. They're able to participate independently. Their parents take them to the competition and it's fine. But there are certain competitions that the school has to say, we are supervising and chaperoning the students and we're taking responsibility for them. So in trying to work through the pilot this year, we are following the same model as sports boosters. So when the track team or the wrestling team wants to go to a competition where only certain kids qualify to attend that competition, usually that is mainly funded through sports boosters. So the PTA has agreed to help support these specialized competitions where it is only entrance is contingent on us saying that we are taking responsibilities for our students at the event. And to do that, they are donating the grant in order to cover our costs because it's outside the parameters of the team, because it's a specialized opportunity for kids. And so as we work through this is a way to get us to a place where our kids can, who really have that specialized talent, have a way that they can continue to compete as we kind of work through this model this year and plan for next year. So we want to thank the PTA for their generous donation and for Josh for working with the PTA and Ron Gamma to try to figure out how to do this. And then I just want to,
just out of curiosity, what style of debate is this for?
Sure, the Lincoln Douglas style of debate specifically. And so our kids are participating in the parliamentary style with Helen Harrison as the coach for the team. And so then, as Ryan mentioned, we have multiple events coming up. This week, we have our Meet the Coaches Night. We have a K-12 Hispanic Heritage Fiesta on Friday. We have a parent support group next week. We have our theater presentation of Little Women. And then, of course, we're going to head into the Thanksgiving holiday. And after that, we return and we have National Inclusive Schools Week. So we're really excited about what's up ahead in the month of November and as we head into December. And I just want to take an opportunity to wish our families a happy Thanksgiving for those who celebrate. And that's the end of the superintendent's report. So thank you.
Any questions for Dr. Ackerman? Okay. Public comment. We welcome public comment and
Committee.
Oh, sorry, I skipped. I'm so sorry.
Committees first.
Keely,
Keely, do you have any?
Yeah, we did.
Health and safety was
Health
after
and
the
safety
last
was,
meeting.
yes,
Yeah.
it was like a few days
October
after.
28th, yeah.
Do you want to talk
Oh,
about it?
It's up to you.
You can talk about
We
it.
could
I'm
commingle
like
here.
searching
Okay.
my memory box.
So yeah, I mean, I guess you could fill in the blanks, what I leave out. We had our first health and safety meeting. Dr. Ackerman, Josh, myself, Kaylee, and consortium. Chief Carroll was there, a bunch of luminaries from the fire department. It was actually a really nice meeting. We did, we broke off into groups. We did a SWOT analysis sort of about relative to the health and safety of all of our schools, which we were identifying strengths, weaknesses, areas of opportunity and threats. I thought it was a really instructive exercise, and there was like widespread participation by like different people in different tranches of each school. We got an update on the progress of the capital projects, air conditioning in the elementary schools. And we also I think we talked through broadening the scope of the umbrella of what health and safety actually means, not just physical safety, but we were also highlighting mental health and support, and obviously in tandem with what we had talked about this evening with our presenters. So I thought it was a really instructive meeting, and I liked how many voices were in the room. So
I did too.
thought we were off to a good start.
Yes. So the one thing that I will say that was different about this Health and Safety Committee meeting is that Christine facilitated the meeting. She normally, previously, it was Josh who used to facilitate the meeting, but Christine is there now. And I also appreciated that we were able to invite, and they accepted our invitation, the first responder, the local agencies, the captains, and the chiefs that were there to just sort of weigh in on what is happening and just be in partnership with the district, which I think is crucial. And there are a number of things that, we've been talking about for years in trying to set up, whether it's drills or having training for the faculty and staff. And I think some of them have already happened, which is amazing. So I think the more voices, there was building level representation. So it was our first meeting, so the attendance was strong. And, I specifically asked that the attendance stay strong because it's really important that people are all in the room together when we are having these conversations around health and safety. Christine, do you have anything to add?
No, I think that what that meeting allowed for us is a roadmap to plan forward on addressing some issues and some ideas that people had brought forward. So at our next meeting, we plan to kind of continue to update on our progress. And I think that, Kaylee, you had made some suggestions even before the meeting started that I think were really important, like offering first aid training and CPR to all of our staff, doing Stop the Bleed training, or offering that as an option during superintendent conference day, and we were able to do those things. So I appreciate your feedback around like things that we could do immediately to help make our schools safer for kids. And so I look forward to being a part of this group. I enjoyed it. So thank you, Josh, too, for helping me co-facilitate.
Alyssa, what do you got?
I got lots. Okay, so we also had our first wellness committee meeting on October 28th, and Andrew and Jamie were there leading us. And we just talked about reviewing what we had accomplished in the past year, and then items that we are highlighting and emerging to work on this year. So we're going to continue with the food tastings. We brought those back post-COVID, and everyone seems to be happy with them. We are going to continue looking at the elementary snack options. Just in general, the middle school experience as it pertains to wellness and mental health, and the new advisory program that we have in the high school. We're going to keep a close eye on that curriculum this year and see how that develops. And Then things for the future, we are potentially looking into our digital technology curriculum. There's a lot of talk around the okay to delay with cell phones, and just in partnership with that, what we're doing to help our kids be smarter with their phones and social media and all of those challenges, and just the overall effectiveness of our mental health programs that we're running here. And I think that the presentation we heard earlier tonight from Northwell is just a really great dovetail to help us all put those things together, because I think our kids, emotional well-being and their mental health is the utmost importance, and probably one of the most important things that we support here. So we're all excited to work on that and wellness. Moving on, I'm also the CSF liaison, and this month at the CSF meeting, I believe Adam was there with me, and talked about the postcards that everyone should have gotten in their mailbox, which focused on the grant that had the electric car, and just talked about some of the events that we're moving forward with. They're going to do the holiday appreciation cards for the teachers again. There's going to be the Wizards game in February. That's always a huge hit. They're gonna pilot a dad's night out as opposed to the mom's night out we've had for a number of years. So signed you guys right up for that. And then of course there's the event in May at Goose Feathers, which is amazing. So if you got this postcard at home and you want to look into CSF, feel free to check out all the amazing things they're doing. And we saw all the Instagrams tonight that are through CSF. So we thank them for partnering with us always and helping us bring stuff to the kids that we wouldn't otherwise be able to. And then we had a bus meeting, but I think Hillary's going to talk about our bus meeting.
Sure. So yeah, this isn't a committee per se, but given that we had the whole presentation, we thought it made sense to keep people updated. So Josh led us in our first electric bus conversion task force meeting last week, and primarily we discussed the recent. If only. That would take one student. We talked about, we started the conversation with what resources are available for us to potentially tap into to help us through this process. And the consensus was we are going to start with the free resources that are available to us because they're free, and because we're all sort of the opinion that this is a bouncing ball, and whereas some version of this mandate is clearly going to be in place and some timeline that we're starting to be on, we are going to need to continue to be on. There's so many moving pieces, and it's impossible to know exactly what trajectory we're going to need to be on. So starting with the free resources seems to be the best course of action. And then when we exhaust those, we'll see what else we have and what we need. But also given that we're getting the demographic study back, and that may change things, and there's so many variables, including will there ever be a bridge over the Sawmill Parkway, which would actually solve 2/3 of our problems. There are just a lot of moving pieces, but we wanted to present that update.
Hillary, do you have any other committees?
I mean, policy met, but it's all finds its way into or not into the agenda. I don't think there's anything to report beyond that we met again. And
I don't think there's we don't have a reading of any policy, but we did talk about Regulation 4020, which is on the independent education evaluations, and also Regulation 7025, student, faculty, and staff freedoms and responsibilities, which was originally proposed as a policy, but now we are looking at it differently, and we've renamed it to be a regulation. But we're not adopting anything today, or reading.
Or reading,
anything.
so
right.
there's
No
not.
reading, no adopting, but we did meet.
Okay, noted.
And just a reminder for everyone, I was thinking this when Melissa was presenting on the Wellness Committee, how I know there were a lot of interest in that particular committee because people are really, concerned about the well-being of our students, and that all of these board committees are open to the public. We don't tape them, but it is open, and they are all noticed. So anyone could come and attend. So just want to put that reminder out there.
Yeah, true. All right, can we do public comment now? Yeah, okay, I've got the order right now. We welcome public comment. In respect for each other's time, we ask that you limit your comments to 3 minutes. Board members may be contacted via email or phone, and after the public comment period has been completed, board members may have a discussion amongst themselves regarding comments presented. Are there any public comments tonight? Please step forward and tell us who you are, even though we know.
Joelle Anderson. I am not here as PTA president. I didn't expect to speak because I didn't even wash my hair. But I feel compelled, basically, about Northern Westchester and the behavioral health centers, and to put on the record and to speak as a mom who had a child who suffered a mental health crisis and navigated the scary world that is quite impossible to navigate when you're dealing with a crisis. And Kaylee, you mentioned an ER. It's the absolute worst experience you can do and go through with your child when that is happening. And then what happens after that, because after you go to an ER and what is expected and what has to happen, what are the next steps? So I feel that I am here to talk for every mom that this, and specifically looking at what they said about Tier 2, I feel personally that Tier 2 could have let us down. If it was here in this school 4 years ago, we would have walked a completely different path with my daughter. So I am compelling you all to get this off the ground as fast as you can. It will save lives. Thanks.
Hi, my name's Tim McNamara. I have 3 children in the district. Really enjoyed watching the elementary school presentations. Clearly we have awesome administrators and teachers. I do want to protest, however, the district's decision several years ago to eliminate one of the 3 elementary school art teacher positions. You know, for anyone who's watching or isn't aware, prior to that, there was 1 art teacher per elementary school who would teach and serve the approximately 400 kids per school. They would host the art shows, and they would also provide subject matter expertise to their principals in building leadership meetings. Since the reduction, for anyone, again, who isn't aware, what happens is that the West Orchard art teacher position was eliminated, I'm told, to fund increased math tutoring. You know, a great thing to add, but really I disagree with taking that funding from our elementary school students. Since the change now, the Grafflin and Roaring Brook art teachers have to each leave their schools 2 days out of the cycle, travel to West Orchard, and try to teach the West Orchard students as well. And as great as our art teachers are, I don't see how we can expect them to connect with each child and teach and educate each child to the same extent that they used to when they had 400 children, and now they're trying to reach 600 students. I think every elementary school in our district should have an art teacher. I was shocked when I found out that we didn't. I initially assumed it was a 1-year gap that we were working to correct. I've since learned that wasn't the case. A bigger picture then, besides the art teacher issue, I just urge you to consider, you know, there are so many great important programs that we need to add, that we want to add, like this mental wellness program. It sounds terrific for our children, but think about how are we going to pay for it? And I urge you to, as we look at what it costs to add that program, really ask our administrators, how are we paying for it? Are we increasing the tax levy or our budget by an adequate amount to fund that mental wellness program without having to cut our core education? Or if we are cutting our core education program, I'd like you to find out exactly what's being cut and share it with the community, because I think everyone deserves to know about the impact that has happened to the arts education for K through 4 students, which is, you know, it's the first 5 years of our children's public education in the arts, the foundation for their creativity. I reached my time? All right, well, thank you very much for your time.
Okay, seeing no more comments, anybody want to have any discussion or? Yep. That's an easy one to.
Yeah, so in the current model, all of our students are getting the same amount of art education in terms of the class that they rotate through. We didn't have to reduce that. We watched a number of sections that we have across the buildings and then try to staff appropriately. It was a decision, I don't remember if it was last year or the year before, that we could cover the number of sections with the 2 art teachers without reducing the amount of art, elective that the students got or encore that the students got. But there is, there is a home school that's assigned, and the art teacher can only be at one faculty meeting, for example. They all happen across the district, so there is some, result of that, of not having an art teacher in each building, but it is important to note that every student is getting the same amount of art education as they were in terms of the class prior to that reduction of that position.
We did that to add the AIS math support. That's part one that we had to reprioritize. So just so everyone understands. Okay, thank you.
Okay, I think we're ready to go to approvals and ratifications. The first one, 3.1, can I have a motion to accept the minutes of the October 23rd board meeting?
I move.
A second.
Any discussion? All in favor? Aye.
I recommend 4.1 instructional as presented with the caveat that you're going to begin to see retirements on the agenda because there's a notification clause around the 1st of December for our contracts attached to a stipend. So we will celebrate all of our retirees in June.
I'll move 4.1. Can I have a second? Any discussion? All those in favor? Aye.
I recommend 4.2 non-instructional as presented.
Any discussion? All in favor? Aye. 5 is the consent agenda. I'm not going to read the description of the consent because our team's been discussing whether we might modify that, but we have items 5.1 through 5.33 tonight to move forward. These include many of the things that were discussed in the update. Is everybody okay to proceed with the consent agenda as written?
So I appreciate that, Ryan. The one thing that I would say 5.4 through 5.9, I think we were supposed to discuss this in exec, but we didn't get to. Am I correct, Christine? It was in
No,
the backup, or you mentioned it, but I don't know.
No, those are everything that we were going to discuss in exec related to the agenda we were able to get to.
Okay. But this, I just noticed that this is something that have we done this before?
Many times.
No,
Many
meaning people coming here. Isn't it? Are people coming here or people going out?
Going out.
Going out, okay. Okay.
Yeah, these are contracts for students that need special services.
Okay, great. And then, just because there were so many, and I appreciated the slides and explanation, Josh, on all the different change orders and increase in purchase orders. I think when there's a dollar amount attached to a resolution, I think people just want to understand better what it's about and why it's happening. So,
Do we need to move this before we discuss it?
did we not move it?
I didn't because, again, we're discussing how to use our consent agenda, and so if we
Okay.
need to do that next, we can.
Can we move it? Thank you.
Okay, so if everybody's fine with what we've got, I was kind of waiting for the yes that, so motion to move the consent agenda then? I'll move it.
Okay.
All right. Do
We're
you
back
have
to
more
discussion now.
Yeah, sure.
Okay.
Whatever else you want to discuss.
So like I was saying, so when there's a large, especially a large dollar amount attached to any resolution, whether it's under the consent agenda or at any other part, I think it's worth talking about and having that discussion just for clarification, because people, you all do this job every day and you guys are the ones in charge of all this work. But that's why I did appreciate those slides and explanation regarding all of those changes. And no, I don't have anything to remove.
Is there any more discussion of any of the other items? All right, so all those in favor? Aye. Okay. Moving on to 6, acknowledging receipt of the following contracts approved by the superintendent per board policy 6085, 6.1 through 6.4. This is services from someone who's helping out one of our teachers, a consultant agreement, and the rental agreement with the club. Can we move 6.1 through 6.4 together?
I'll move.
Any discussion of these 4? Just acknowledging receipt of them? All in
Right.
favor?
So wait, so this is just an acknowledge of receipt.
Yeah, we
This is
saw
not,
it.
this is not the board approving
Correct.
all of those items. I just want to clarify that.
That's right. All in favor?
Aye.
7, we've got 7.1 and 7.2. These are acknowledging change orders approved by the superintendent. So again, we're not approving these 2 items. We're just acknowledging that we got the documentation about them. 7.1 and 7.2. Can we move those together? I'll move those. Any discussion?
Yes, I have a question. I don't know if this was a typo. It says, under facilities, under 7, be it resolved that the Board of Education acknowledges change orders approved by the superintendent per board resolution adopted at June 14, 2017 Board of Education meeting.
That's when the resolution went into effect.
Okay, so then I just need to understand what this, I just didn't understand it.
Okay.
So can somebody just explain that?
So for items under a certain amount,
So items under 7.1 and 7.2.
I think what was, I'm not sure if this is the question you're asking.
Well, I just don't understand it at all.
So I think that in June of 2017, the board approved a resolution that they would want to be given change orders that the superintendent approved so that the board was kept apprised of what was going on in the process. So that was the June 2017 piece of it. And then we are acknowledging the change orders that Dr. Ackerman approved.
So what is the difference then to these change orders versus the change orders that are now in the consent agenda under the 5s? And then what is there a threshold in terms of number?
The resolution was passed, the superintendent could approve change orders of $40,000.
yeah, so it's an amount threshold.
And that the board would then, at the very next meeting, acknowledge that those change orders have been approved.
Okay, so,
Anything over $40,000, Board of Education must approve.
and that is just for change orders?
That's correct.
Because there's another one where the superintendent has
Yeah, for purchasing.
authority,
Different.
right, okay. So
Yeah.
I just wanted to make sure I understood that properly. Okay, thank you.
All right, so all those in favor for 7.1 and 7.2?
Aye.
Number 8, financials. Here we're going to acknowledge receipt of 5 items. The claims auditor's report for September 2024, claims auditor's report for October 2024, treasurer's report for October 24, appropriation status report for October 24, and the revenue status report for October 2024. So can I get a motion for 8.1 through 8.5?
Second.
Any discussion of these? All those in favor? Okay, and notice of future meetings. We'll be together next on Wednesday, December 11th at 7 o'clock here, and we'll have the middle school program presentation that day. And then we will not be meeting again until January 15th at 7 for the budget preview. And I need to check the time. Can I have a motion to adjourn at 8:42?
Second.
All in favor?
Aye.
Okay, we're out.
Good work.